A very good morning to one and all of you. It's so nice to see so many at the first session of the day. But that's how is Dr. Priya's course. Besides being a dynamic person herself, she has brought out a most relevant topic which hits us on our face on a day-to-day. So I'm actually just collected simple videos which is going to be very relevant to us, because PCR itself is a catastrophe which we are not ready for. And what is more important now is how are you going to place the lens with a PCR sitting right there. And this is how I'm going to deal with it. All simple situations. This is a well-dilated pupil. And you know, it's one of those large part of my cases. I have a nice round rhexis. I'm quite complacent, but there's one suspicious area. But I know it's just a PSC, it's not a PPC. I do a gentle hydro, decompress it, and inject viscoelastic. But still the suspicion's there, but then it's rotating, so there's no vitreous yet. So I thought I'll do a simple stop and chop, but I find that I've just eaten a superficial segment, then I go and make a trough. There is that clearing there, you can see very well that I split the nucleus. But this, if vitreous was there, I couldn't be rotating it because it will not allow rotation of the fragment. So then I think it's just a clear PC which is shining through. And then, but keeping my parameters low, keeping in the central pupillary plane, I eat up one fragment. Now it's still rotating, things are still going good. There's no PCR there, there's no vitreous. But by now, I know there's a large vitreous, but a large area of vitreous. So, but then I've already got this epinucleus there, so I try to eat it up, but now there's traction, I let go. And the best thing to do is to inject Viscoat, which is a viscoadaptive viscoelastic, which should push the vitreous behind. And there's just this small amount of epinucleus. So though it's not allowed to take the phacoprobim, I go in and take it out. Again, there's traction at the vitreous, and it'll go and pull at the vitreous base. So now I do a gentle, good anterior vitrectomy. And then the ease with which I'm able to remove the cortex is actually another clear indication that the vitreous has totally got cleared. So I go ahead and tease all the cortex, and things look fine. And a horizontal PCR, there's so much support up, so much support down. I think, no, I'm going to go and place. After all, I'm going to just inject a 3-piece IOL in the bag, so it's fine. But I'm going to put it into the bag, mind you. So I enlarge the incision, and then I position this 3-piece IOL, and then nudge it and position it onto the posterior capsule in the support which was above and below. And it looks centered. I wait for a bit. It looks all good. So then I decide I'm just now, oh yes, I have to remove all the viscoelastic. The job is not done. So I go aggressively behind the IOL. I go in front of the IOL. And then things look okay, but then there's a little doubt which is coming into my mind. I see that the haptic is sliding down, and I realize that this is not the scaffold place for the 3-piece at all at this point of time. The support is inadequate, and then it becomes all jugglery, because now I have to get the 3-piece out of the bag onto the sulcus, and it was absolutely foolish of me to have placed it in that feeble support. So the moral of the story here is that if you have a PCR, the best way to do is to, if you can, convert the PCR into a PCC, which remains fine and stable, and then you could inject your 3-piece IOL in the bag, and that could have been a solution. Now this is again an old video, but it has relevance at this point of time. The silicone oil is now, we all know, we remove it from the posterior root, but earlier days we used to remove it from the anterior root too. So it's a routine case. I'm doing the phacoemulsification and things are going good. And now there's nothing there, so I create a PCC here, because I'm going to remove the silicone oil from the vitreous cavity. So a small PCC is created, and you have all the silicone bubbles being removed with just an infusion on, and it's just a story getting over. And now with jubilation, I push in a 3-piece IOL into the bag. Now again, see, the PCC has enlarged, and now again I know that I have to now push it back onto the sulcus. So there is a message here. If you have done a PCC, fine, but not a 3-piece IOL into the bag, because of the forceful injection, the way the haptics open up, it would quite possibly rip the PCC, in spite of the fact that we see the PCCs are good. Now this is again a PCR, and I have actually expected it to be a complicated surgery. I have pressed the Malugins ring, and then here this PCR I'm converting into a PCC, a small eccentric PCC I've done. There's no vitreous presenting yet. I just enlarged the incision a bit. I need not have, but I didn't want any kind of forceful injection. and I'm going to inject a single piece IOL into the bag, but I don't want it to forcefully land on the posterior capsule and again rip the PCC. So I keep a second instrument as a scaffold here and allow the single piece to gently unfold into the bag. Not exactly into the bag, it's still on top of the bag. And don't want to stretch the posterior the capsular bag. I just gently nudge the haptic into the bag and do the similar thing in the other so that the PCC remains intact and the things are quite stable. Now this is another interesting case here. It's a posterior polar cataract with those riders. When you see these kind of posterior polar cataract, you could be sure that you're working on an open posterior capsule there. So then you need to fashion out a nice round rhexis because you know the IOL is going to need this scaffold. There's a great chance that the posterior capsular rent has occurred. So then, of course, you can't do a hydrodissection. I'm just do a gentle visco separation of whatever it's worth. It's done. And then gently, the whole surgery has to be gentle, phaco parameters. I do a gentle stop and chop, inject viscoelastic in the bag so that there is no alteration in the hydrostatic pressure in the bag, no anterior chamber shallowing, anything which would allow that area of vitreous to come from that area of dehiscence in the posterior capsule. I nudge the epinucleus, and thankfully, in this situation, it just comes off, all folding on itself. It was a sheer chance. Sometimes you're really pulling at the epinucleus with the posterior polar cataract because you've not done a hydrodissection. I inject viscode through the side port, again to plug the vitreous, which has yet not come forward. But look at the ease with which the cortex is being teased out. That is an indication that the vitreous is still in bay, it's still in the place where it should be. It has not come forward. It is a horizontal PCR, but you know, I've already learned my lesson. I'm not going to be fooling around by placing a three-piece IOL into the bag, and then I inject a three-piece IOL onto the sulcus. But as was very well discussed here, of course, I'm going to remove all the debris, the viscoelastic in front of the IOL and behind the IOL, and then I would nudge the optic of the IOL into the round, deep below the rhexis, and keep the haptics on the sulcus. And this is the optic capture which we have, an ideal situation, and this is a well-centered IOL, and it would actually achieve the target emmetropia which you're looking at. Now this is again a very innocuous normal case. I've nearly come to the end of the surgery, but look, centrally there's a small flap. Now I could have gone in and converted into a PCC at this time. I keep the phaco probe in. I do not want shallowing in the anterior chamber, no change in the hydrostatic pressure. Inject viscoelastic through the side port and then gently bring my phaco probe out. And look what I'm doing. I'm now gently injecting a single piece IOL into the bag. Now again, there's a small PCR there. I haven't converted into a PCC. So I'm going to gently nudge the single piece into the bag, folding the haptics without stretching the capsular bag. And look what this IOL is to do. It is going to act like a scaffold, which is going to keep whatever vitreous might come forward, it keeps it behind. And then I remove all the cortex gently and thus bail myself out of this case as a routine situation. Now this is another case where I'm nearly at the end of the surgery, and then undercelly there is a PCR, and the nucleus is actually gone subincisionally, which is rather a difficult position to deal with. But then there is no vitreous there, thankfully. So I realize it's quite a chunky piece of nucleus. So with my side port instruments, I bring it forward. And now I inject viscoelastic underneath the IOL, enlarge incision. This is a clear-cut case where there's going to be no fooling around. You have to have a scaffold of the IOL placed below this nuclear fragment. Now there are two choices. You could leave the haptic on the iris, or if there is no vitreous disturbance, you could place it in the sulcus. As there was no vitreous disturbance, I placed it in the sulcus. And then, of course, I am in front, the supracapsular space, try my best to keep away from the endothelium and eat up this nuclear fragment. And then the story is not over. Now I go behind the IOL, I do a good vitrectomy, ensure I remove all the vitreous and all the debris which is there, and there's a little bit of vitreous which is there in the forward, come in front, inject tricot, see whether it's completely cleared because it's going to well delineate the vitreous stance, do a good vitrectomy, and then the case is done and complete. This is the last of the scenarios which I'm showing. The case was done, and the patient comes the next day with an epinuclear fragment behind the IOL. So then I place my trochos. I understand that this case is not meant for an anterior vitrectomy. Anterior vitrectomy surgeons, unless you are great at doing a pars plana, it's better you stick to the anterior route itself. It's a worth learning. But this is a case where you need to go through the pars plana route because the IOL is sitting in the bag. So you do not want that area of PCR to enlarge. And when you are cutting the vitreous at its home, where it is located, there's not going to be as much of a gush of vitreous forward as if you had gone into the anterior route. So you go behind, do cut all the vitreous, the PCR area does not increase, the IOL is quite stable, and then you inject tricot to know whether there has been a proper vitreous has been completely removed, and then you end up with a safe situation. So there are any number of ways with which you could deal, but the three main messages I want across is if you have a PCR, you can convert it into a PCC, go ahead and do it. Don't try to inject a 3-piece IOL in the bag if you have a PCR. You can try, if there's enough support, inject a single-piece IOL into the bag, and that too as gently as possible. And if the case allows, use your IOL as a scaffold to remove the nucleus or the cortex, because that acts as a tamponade for the vitreous from coming forward. I hope I was able to get something across. Please remember this phaco-refractive decoded, which we are having at our place at the Eye Foundation for June 7th, 8th, and 9th. We have a good scientific content ready for you there.